This is a Dutch testing report tutorial to assist you with understanding of results. These videos are all for educational information only, not to be taken as medical advice. The results that we'll show on the screen are not those of any particular patient. The results that we want to look at for cortisol, there's a lot of data, but the most important results that we want to see is first off the cortisol pattern, the free cortisol pattern over time. So we've got four measurements. We've got a waking measurement, which reflects the cortisol, the free cortisol overnight. And then the morning sample represents the first 2 hours of the day. In a normal, healthy person, usually that's going to be surging up quite a bit. And then back down to the afternoon measurement, and then usually lowest at bedtime. Then we'll add those up to create this number here. In this particular case, those are pretty low. And in this particular case, that's not unexpected because there is, at least was noted, supplementation with glucocorticoids. So the degree to which this is suppressed may have to do with the dose of the glucocorticoid, prednisone or whatever it is. We want to be careful with the interpretation, knowing that the patient's taking that. Okay, so we expect pretty low results, and we get that. But then when we shift to looking at the metabolized cortisol, that's your better marker for overall production of cortisol, because the free cortisol only represents about 1% of the total, whereas the metabolites represent about 75% of the total. And in this case, they're either normal or elevated. And if they're normal, if they're on the lower side of normal, you probably still have suppression going on from the glucocorticoid. As we get a bit higher, then it becomes a little bit ambiguous or maybe counterintuitive as to whether it's actually suppressed or not due to the glucocorticoid use. So if you have lower levels of free cortisol, which we do in this particular case, and then normal or more elevated levels of the cortisol production, that may imply that there's increased clearance of cortisol. So when cortisol is made, it interconverts with cortisone by an enzyme called 11-beta-HSD. So it's got its active form, it's got its inactive form of cortisone. It circulates as either of those. So when you want to look at the cortisol pattern, also take a look at that cortisone pattern. It's of secondary importance, but it's good to confirm kind of what's going on. So those are available in the free form, and then they get metabolized downstream to cortisol and cortisone metabolites, which again are not low in this particular case, which implies that there isn't a total deficiency of cortisol production. And when that free cortisol is low and the metabolites are higher in a relative sense, it implies that there may be increased clearance of cortisol. So if the patient's taking glucocorticoids, or has been historically, and isn't taking them now, or isn't taking a dose that's large enough to suppress cortisol production, one of the things going on here could be that the use of a cortisol-like metabolite has potentially increased the clearance, the metabolism of cortisol, to give this sort of a look where you've got the lower free cortisol but more elevated production of cortisol. So cortisol gets complex, and especially when you start taking cortisol or taking glucocorticoids, and we need to look carefully at the free cortisol over time as well as the metabolites. One of the other things we can see from the metabolites is which ones we have more of, the active cortisol or the inactive cortisone, and that helps add to this overall picture and characterization of the patient's cortisol as well. So I hope that's been helpful. If you have any questions from the patient perspective, please do see your healthcare provider about those, and we thank you for testing with us.